Ê, Right. Shall we start then? Can you hear me? Hello? Yes, right. Let's start from this question number 18, right? We are going to do few MCQs on thyroid and parathyroid as well, right? Question number 18 regarding the anatomy of thyroid gland. Superior thyroid artery is related to the external laryngeal nerve. What is your answer? Superior thyroid artery originating superior thyroid artery. It's a branch of which artery? True. Superior thyroid and inferior thyroid arteries are branches of where those arteries are originating. Superior thyroid artery comes from the external carotid. Inferior thyroid arises from the costocervical trunk of the subclavian, right? Then superior thyroid artery is related to external branch of the superior laryngeal nerve, and the inferior thyroid artery is related to recurrent laryngeal nerve, right? Those are the relations. So when you are ligating the superior and inferior thyroid arteries, you have to safeguard these nerves, right? Then okay, we'll talk a little bit about anatomy of the thyroid gland after completing this MCQ, right? Recurrent laryngeal nerve runs close to the inferior thyroid artery. Yes, that's true. Recurrent laryngeal nerve actually goes through the branches of inferior thyroid artery, or sometimes it goes anterior, posterior branches, right? It's mainly related to branches to the inferior thyroid artery. Inferior thyroid artery arises from external carotid. That's false. Superior thyroid artery is the one which arises from the external carotid. Middle thyroid vein arises from internal jugular vein. That's true, right? Middle and superior thyroid veins draining to internal jugular vein, and the inferior thyroid veins drains to brachiocephalic trunk, right? Brachiocephalic. Thyroid has multiple inferior thyroid veins. That's true, right? We'll just a quick review on this. Anatomy, right? This is, can you see this presentation? PowerPoint slides. Right. Then arterial supply of the thyroid gland, superior artery arises from external carotid and relates to external laryngeal nerve. That's what was in the question, right? First step. Inferior thyroid artery arises from the thyrocervical trunk, and which is a thyrocervical trunk is a branch of subclavian, right? That is second part of the subclavian artery. Gives the thyrocervical trunk. One of the branches of thyrocervical trunk is the inferior thyroid, right? And it relates to recurrent laryngeal nerve. And there's another artery, thyroid ema, which present only in 3%, and basically it supplies the pyramidal lobe, right? It can be arising from either arch of aorta, right common carotid, or brachiocephalic trunk itself. Fuel. These are the arteries which we are talking about, right? The superior thyroid arises from the external carotid. Inferior thyroid arises from the thyrocervical trunk. Thyrocervical trunk is a branch of subclavian, right? And this thyroid ima, which supplies basically the pyramidal lobe. Right? And venous drainage, superior and middle thyroid veins drains into internal jugular vein, and the inferior thyroid veins drain mainly into left brachiocephalic vein. Right? That's it. And these nerves, basically this external, we are talking about this external laryngeal nerve and the recurrent laryngeal nerve in relation to arteries. And this so superior laryngeal nerve divides into external and internal branches, right? This external branch of the superior laryngeal nerve, it is a branch of vagus. It is closely associated with superior thyroid artery, right? When you ligate the superior thyroid artery, you have to safeguard the external branch of the superior laryngeal nerve, right? You closely dissect, and you have to ligate only the artery, right? If you damage this external branch of the superior laryngeal nerve, this nerve supplies the this only muscle which tends the vocal cords. What is that muscle? Cricothyroid, right? And if this nerve getting paralyzed, if this nerve getting if it is get injured, patient can't produce high pitched voices, right? That is the significance of the external branches of superior laryngeal nerve, right? It's recurrent. If you damage the recurrent laryngeal nerve, patient will develop vocal cord folds, right? If it is a complete, if it is a partial abrasion, partial damage to the nerve, if it is an abrasion, all the abductors of the vocal cord, abductor muscles of the vocal cords will be paralyzed, and vocal cords will be adducted, right? And patient will develop complete upper eye obstruction. If it's a complete pulse of the recurrent laryngeal nerve, these vocal cords will be positioned in cadaveric position. Patient will develop hoarseness of voice, but they won't get upper eye obstruction as such, right? And this is the relation to this is the inferior, how this is how recurrent laryngeal nerve relates to inferior third artery. It can go anterior, posterior, in between branches of the inferior third artery, right? Then lymphatic drainage of the thyroid. Basically, lymphatic drainage of thyroid drains to level 2 to 6, right? And minute part drains to level 7 as well, right? That is level 7 means lymph node is in a superior mediastinum. Infraclavicular. This level 1 nodes mainly it is drained from the sublingual region, right? Lingual and sublingual salivary glands, right? So when you do a lymph node dissection in a local inverted thyroid, for local inverted thyroid malignancy, you don't remove level 1 lymph nodes. You dissect from level 2 to level 6, right? That is the level which is a hugely disseminated. You will sometimes dissect level 7 as well. Mainly you go dissect level 2 to level 6, right? Right. Then little bit about parathyroid. Parathyroid mainly supplied by inferior thyroid artery, right? If you ligate the main trunk of the inferior thyroid artery. Both pair of all four glands will be ischemic, right? Then patient will develop postoperative hypocalcemia, right? So in the current practice, we ligate the branches of the inferior thyroid, not the main trunk, right? And superior parathyroid artery originates from the fourth branchial arch, right? Inferior comes from the third branchial arch. That's why it is called parathyroid 3. And inferior parathyroid is embryologically originates from the third pharyngeal arch with thymus, and it descends together. Superior parathyroid artery location is a bit constant, but inferior thyroid sometimes it is located in the associated with the location of thymus, or sometimes descend up to superior intestine, right? More anatomical variations of the position will be seen in related to inferior parathyroid artery, right? That is about anatomy of the thyroid, right? And coming back to this question, so you can answer, no? All this, right? That's regarding anatomy. Sometimes there will be a question on thyroid anatomy, because thyroidectomy is one of common surgeries we perform. So they will put questions on thyroid anatomy, right? You have to know a little bit about this, right? Then we'll move on to this, right? Question number 8. 16-year-old girl presented with diffuse enlargement of the thyroid gland for 6 months. Which of the following test is the best initial investigation? Right. How do you approach this? Can you please tell about unilateral and bilateral recurrent nerve damage and how it affects its partial or total damage to the nerve? Yeah, there's a question, right? There's a question that unilateral is asking about unilateral and bilateral recurrent laryngeal nerve damage and how it affects it, if it's partial or total damage. Yes. If it is a bilateral nerve damage, right? And if it is a complete nerve injury bilaterally, both the vocal cords will be positioned in cadaveric position. That means it is not abducted or either abducted or adducted, right? So airway will be patent, right? But patient can't produce any sounds because he can't move the vocal cords. All the muscles which are supplied by the recurrent laryngeal nerve will be paralyzed, right? If it is a partial nerve injury, bilateral partial nerve injury, mainly the muscles which are getting paralyzed will be only the abductors. Adductors will be working, right? So, because these abductor muscles will be abductor, that is, muscle is a posterior cricoarytenoids, right? Will be paralyzed, and other adductors will be working. So undue action of the adductors will lead to complete obstruction of the upper airway, right? Both the vocal cords will be fully adducted. So it will be a complete upper airway obstruction, right? That is why complete nerve bilateral nerve pulse is better than partial recurrent laryngeal nerve pulse. Right? Reason for this, only abductor muscles are getting paralysis. This outer nerve fibers mainly supplies the posterior cranial, right? Rest of the nerve fibers go and innervate the adductors, right? That's the answer for that, right? If it is unilateral nerve palsy, there won't be airway obstruction, right? Even it is a fully adducted or adducted or in cadaveric position, it won't lead to complete upper air obstruction because other vocal cord is moving. Patient will develop hoarseness, right? Upper air obstruction occurs only during partial bilateral recurrent laryngeal nerve palsy. Usually, in other circumstances, there will be some degree of obstruction, upper obstruction in unilateral vocal cord palsy, but it won't be a severe as in bilateral nerve palsy, right? Right. Are you clear with that explanation? Can all hear me? Is it clear? Or? All right. Okay, then there's a diffuse enlargement of thyroid gland for 6 months in a 16-year-old girl. Right. What is the difference between this diffuse goiters and the now in regarding this question, what is this clinical condition? What is this? What does this child is having? Why this diffuse enlargement? What is the reason? Most probable reason? You want to answer? Physiological goiter. Yes, she is in puberty. Demand rises, so a gland tries to reach the demand by producing more thyroxine. So gland will be hypertrophic, right? So patient this diffuse gland is diffuse enlarged, right? Entire gland is symmetrically enlarged. So in this clinical scenario, next investigation should be thyroid function test, right? Not the you don't have to assess the structure. Usually we do both the ultrasound scan and the TSH, thyroid functions. But if you are being asked about the best initial investigation, it should be thyroid function test, basically TSH, because since it is diffuse enlargement and clinical picture more towards this physiological goiter, you don't expect much to take from a ultrasound scan, right? It will be obviously diffuse enlargement, and by doing TSH, you can decide whether a patient is euthyroid or not. Right? If TSH is normal, you don't have to do anything. Right? That is the idea. Right? If it is a nodular goiter, then things will be different. Right? Then anyway, tell me, what is a goiter? What is the definition of goiter? Why can't it be Graves? Yes, in the Graves disease also, you will get diffuse enlargement, right? Diffuse enlargement, and patient will be thyrotoxic, right? Patient will be hyperthyroid, and they will develop eye signs, right? But this clinical picture more towards physiological goiter, right? This is chance. Anyway, there's my chance, right? But when you read a case scenario in a MCQ, You have to think about best possible DDs, and with regard to that, you have to pick an answer, right? Even if it is a Graves' disease, it's a clinical diagnosis, and your next line investigation should be TSH, not the ultrasound scan, right? If it is nodular, yes, you have to assess the nodules, right? Because of yes, because of her age, we suspect this could be physiological goiter, and even if it is a Graves, answer won't be changed, right? Next line investigation will be TSH. Right. That's about diffuse enlargement. Right? Then so the same question, number 2, no? Number 3. We go to nodular is thyroid nodule question regarding them. Right. Number 6. Again, 24-year-old female presented with thyroid swelling with solitary nodule. What is the most appropriate investigation? Right. How do you evaluate a thyroid nodule? Tell me the definition of goiter. Definition of goiter. What is a goiter? Anyone to answer? What is a goiter? Definition of goiter. Diffuse enlargement of thyroid gland. No, it's not the correct answer. Enlargement of thyroid. Yes. How much? It is called. It is visible or palpable enlargement of thyroid gland from any ETL. Yeah. Yes, there can be subclinical or clinical goiters, right? Which whether you can either you can you can see from outside, you can inspect, or you can feel, palpate and feel, or you can detect by, that is, if you can see or feel, that is clinically evident goiter. Subclinical means you can't pick it from your examination. Ultrasonally, you can see there's a enlargement, right? Definition, it is called enlargement of thyroid gland twice the normal size or weight more than 40 grams. Right? That is the definition. And how do you divide goiters? Clinical classify goiters. Main classification. Mainly, goiters can be the diffuse enlargement or nodular, right? Nodular. In nodular goiters, it can be either solitary nodule, or it can be a solitary nodule, dominant nodule, or multinodular goiter. What is the difference between this dominant nodule and the solitary nodule? What is the difference between this dominant nodule and solitary nodule?
The solitary nodule.
Yes. Wait, there's a mute, right? Okay. Dominant in a multinodular goiter. It's part of multinodular. No. In the solitary nodular goiter, you can only feel one nodule. Rest of the gland is not palpable, right? In the solitary nodular goiter, only the only one nodule is palpable, rest of the gland is also not palpable. In a dominant nodule, there can be subclinical nodule. It can be dominant nodule, multinodule goiter. So with this dominant nodule, there will be a small. The rest of the gland is palpable. That is the main difference. So it can be, there can be a small nodule. So you won't find any other nodules because those are smaller, but gland will be palpable. Gland will be palpable, right? Multinodular goiter, obviously there will be many palpable nodules, right? Go with this classification, then that idea should be there. Yes, this is the goiter, right? Twice the normal size of over 40 grams. That is definition. And WHO, do you know what is WHO classification? Grade 0 is not palpable, right? Subclinical, right? Grade 1A is palpable but not visible from outside. You can't detect the goiter by inspection. Only palpation you will elicit. There is a thyroid. In grade 1B, this goiter will be visible when the neck is extended, and when you stretch the muscles, when you change the position of the neck, it will be visible. Only with extended neck, you will see the goiter, right? And grade 2, you can detect the goiter in inspection. Grade 3, it is visible from a distance as well. That is the WHO classification. This clinical classification, mainly diffuse or nodular. Nodular classification, again, fall into 3 categories: either solitary nodule, dominant nodule, or a multinodule, right? This multinodule goiter is where it is a palpable gland with palpable multiple nodules. In solitary nodule, this is palpable single nodule, and rest of the gland is impalpable, right? Rest of the gland is impalpable. Dominant nodule, this is a palpable gland with a palpable single nodule, right? That these are the things when you examine a thyroid, you examine each lobe separately, and you have, after your palpation, you have to have an idea whether it is a diffuse enlargement or nodular enlargement. If it is nodular, whether it is a multinodular goiter, whether it is a dominant nodule, where I only feel a one nodule without palpating rest of the gland, or it is a solitary nodule. You have to have an idea about this classification after palpating the gland in your examination, right? And these goiters can be either toxic or non-toxic. Means a patient can be hyperthyroid. That is meant by toxic. It can be either euthyroid or hypothyroid. That means non-toxic. And these goiters can be benign or malignant. Right? Those are the 3 main factors you consider in clinical classification of goiter. Whether it is diffuse enlargement or nodular. If it is diffuse enlargement, mainly you will think about these physiological goiters and graves, or even thyroiditis, you will get diffuse enlargement. In nodularity, whether it is multinodular goiter or solitary nodule or dominant nodule, right? Then you check whether the patient is hyperthyroid, hypothyroid, or clinical euthyroid, right? And you benign, whether benign or malignant, again you can have some idea after your examination whether if it is a hard nodule with irregular margins, irregular surfaces, right? And with associated cervical lymphadenopathies with this hard consistency. And if it is history suggestive of malignancy with recent rapid enlargement, local invasions with the recent change of voices, hoarseness of voice, and if there are any features suggest of local invasion or dose meds, then after your examination, you can have an idea whether this can be malignant or benign condition. Right? So all these three factors will be addressed by your history and examination, right? And so depending on this clinical presentation, your management will be different, right? Coming back to this question, this patient is having solitary nodule, right? 24-year-old female with a solitary nodule. That means there's only one palpable nodule and the rest of the gland is not palpable, right? And if you have this sort of a clinical presentation, your main worry is whether it is malignancy, thyroid malignancy or not. Then your next line investigations will be to assess the, after your history and clinical examination, targeting this, whether it is malignant or you go through these main three factors, whether it is a diffuse or nodular enlargement, whether the patient is hypothyroid, hypoeuthyroid, and whether it's benign or malignant. Then from your investigation also, you address these factors. You are going to exclude the thyroid malignancy, right? So you do thyroid function test. Initially, you do TSH levels if the patient is clinical euthyroid. If the patient is hypo, you can at the same time you can order T3 and T4, but usually start with TSH, right? TSH to check the function. Then you do ultrasound scan of the neck. What do you expect to see by ordering ultrasound scan? What are the things you look at by doing an ultrasound scan in a thyroid? Thyroid, solitary nodule, goiter. Cystic or solid, yeah. Vascularity, hyperechoic. Yes. You're answering right. Go on. Lymph nodes. Yes. Again, when you're being questioned in your long case, even what do you expect? You can be questioned like this. What do you expect by doing that? What do you want to achieve by doing ultrasound scan? By doing ultrasound scan, you will assess thyroid gland and cervical lymph nodes, right? In thyroid gland, assessment of the thyroid gland, you will assess this clinically palpable solitary nodule with regards to malignant features, whether it is cystic or solid. If it is solid, more towards malignancy, right? And if it is larger, again, more towards malignancy. And the hypoechoic nature, microcalcifications, taller than wider diameter, right? Increased vascular all leads towards malignancy, right? And this you assess this palpable solitary nodule, and you assess the rest of the gland as well. You look whether are there any more nodules, and how about the rest of the gland, whatever the other lobe, and you will check whether there are any lymph node enlargement and whether there are any malignant features of these lymph nodes, right? The features of dissemination. It's same as your breast lump assessment, right? Then if you find a suspicious nodule, right? Solitary nodule, suspicious nodule, and this thyroid ultrasound scan of thyroid again reported according to universally accepted nomenclature that is called THYREDS, right? thyroid imaging, reporting and data system, right? So it gives thyroid, it again runs from 1 to 5, right? It gives the clear picture is benign or malignant, and it directs you to it gives you the opinion whether this nodule is needed to be assessed by FNAC or not, right? Right. Then you know, if the nodule if it is a solid nodule, and if it is hypothyroid, and if it is a larger nodule, and if it contains this solid component, those are more towards malignant features. And solid nodule you will further assess by ultrasound guided FNs, right? Now this our practice with regard to thyroid. Now we do ultrasound guided FNs even if it is palpable, because that will be more sensitive than FNAC without ultrasound guidance, right? So we do FNAC with ultrasound guidance. That should be the best correct answer here. They have mentioned only FNAC. So that is the answer. Radioactive iodine, isotope scan, CT, X-ray, all those are not. You do CT scan chest, right, to assess the red cross translation. If it is malignancy, to state the disease. To state the disease, you will do X-ray neck to assess the tracheal position, right? If you're preparing for surgery, if you prepare the patient for surgery, do the X-ray cervical spine to assess the trachea. And this isotope scans, yes, do to assess the function of the nodule, whether it is hyperfunctioning or hyperfunctioning nodule. But before that, right? Before that, if it is solid nodule, you do FNAC, right? But if the patient is thyroid toxic with solid nodule, yes, you can go and do a isotope scan, because in hyperthyroid solid nodule, there's a minute chance to become malignant disease, right? In that sense, you can do, but at your level, because this question is in this question they haven't mentioned anything about the thyroid status. So patient with the thyroid swelling with a solid nodule, you have to always think about malignancy. If this nodule is hyperfunctioning, clinically patient is hyperthyroid, you know, you don't, sometimes you can directly go to isotope scan without doing FNAC, because it's more towards thyroid adenoma rather than malignancy, right? With regard to this question, answer should be FNAC. Fine needle aspiration it should be guided, right? So if thyroid profile answer they are as answers, what would be the answers? If also answer in this question, which one we should consider as correct? Then what is the most appropriate next line investigation? Yes, most appropriate next line of investigations should be TSH and ultrasound scan, right? You can't say this should be the ultrasound scan should be done before TSH as such, because in this condition it's not a diffuse enlargement. You can't forget about ultrasound scan. So both the investigations are important. Huh? You can't choose one or the other. Both the investigation should come first before FNAC, ultrasound scan neck and thyroid function TSH. Then comes the FNAC, right? If those they have given those two options, because then you can't choose a one answer. That's why they have omitted, but that should be the line of investigation, right? Thyroid function with TSH plus or minus T3, T4, ultrasound scan. Then depends on those findings, you plan for your cytology or histology, right? Merely FNAC, then you plan further management, right? Are you clear about that? Do you need any more explanation? Anyone? Any questions on that? You all clear about this solitary nodular goiter, dominant multinodular goiter? Right. If there is a larger nodule in multinodular goiter, you will, with suspicious features, then you assess that particular nodule with FNAs, right? Guided FNAs. That's how it goes, right? Right. So number 6, 7. Right. Okay. Number 7. 30-year-old female has a solitary nodule on thyroid. The FNA shows follicular neoplasia. What is the most appropriate management option? Okay. Tell me the answer. Well, don't tell it. T. Okay, go on. What is the answer? E, because neoplasia. D. Right. Okay. Most of you all have chosen the answer as D. Right. That is the correct answer. And with regard to FNAC, again, they report according to Bethesda classification, right? Bethesda classification. And Bethesda 3 is follicular proliferation, no? 4 suspicious, 5 malignant, right? Well, for this, the 1 is inadequate sample, 2 benign, 3 ATP, 4 follicular neoplasia, 5 probably malignant, 6 malignant, right? 1 to 6. So it is 4. This is 4. So you detect follicular neoplasia in a solitary nodule, right? Why do you do a hemithyroidectomy? Why do you do a hemithyroidectomy? You have chosen this. You have to take the FNAC cannot differentiate adenoma and follicular adenoma and carcinoma. Yes, right. Why can't okay, FNAC it's cytological. Why can't you do a core biopsy? You do core biopsies in breast lump, no? Why can't you do a core biopsy? This we don't do core biopsies in the neck, blood vessels. To see, yes, you do hemithyroidectomy to see the capsular vascular invasions, not the infiltration invasions. I'm asking whether is it impossible to do a core biopsy in thyroid nodule? Possible, yes. Then why we don't do core biopsies? Actually, we can do. There's an ongoing trial, right? This is now everything is evolving now. Any malignancy now, as we try to preserve as much as possible, right? Even in breast, even in thyroid, our intent is to preserve as much as possible healthy tissues because it will reduce the morbidity after surgery, right? This is only a nodule in one lobe of the thyroid, right? Yeah, one part of thyroid, if you can do a core biopsy and exclude thyroid follicular carcinoma, right? Then that's all. But thing is, it's not sensitive enough. Core biopsy, even frozen section, they have tried frozen section biopsies as well. In literature, they have done all this, and still what is this? Trials are going on with regard to core biopsies in solitary nodules, right? They have found up to now, what they have found is it's not sensitive enough. They can miss follicular carcinomas by doing core biopsy and frozen sections, right? Because they can't correctly assess the vascular invasion and capsular invasion, because they have to take entire lesion to assess them, not like in breast. Another thing is, yes, core biopsy, it's a highly vascular neck thyroid is related to carotid sheath, esophagus, trachea, important structures and nerves. You can damage. Still, you can do guided core biopsies. You can do. You can safely do if you are skillful. So it is not impossible. There's one. We don't do it frequently without any ultrasound guidance. Yes, there's a risk of damaging structures, but in future this will come up, right? They will find a way to preserve the gland without losing a lobe, because if it is adenoma, you have already taken out half of the gland. And lobectomy, thyroid lobectomy is a major surgery with comorbids. You can damage nerves, recurrent laryngeal nerve, external laryngeal nerve, right? And even carotid sheath. So it carries some degree of morbidity. It's better if you can avoid. So still trials are going on, but at this level, yes, since you can't differentiate follicular adenoma from follicular carcinoma by FNAC, because you can't assess the vascular and capsular invasion by cytology, you need tissue diagnosis. So you have to sacrifice one lobe of thyroid. So next step, appropriate management should be hemithyroidectomy. Right? Hemithyroidectomy, radioiodine ablation, total thyroidectomy, all are out, right? And you send you do the hemithyroidectomy, send the sample to histology, assessment. If it is follicular carcinoma, right? It is follicular carcinoma. This is they have asked question, no? Regards to investigating the solitary nodule, next line investigation would be ultrasound rather than thyroid function. Or still we could go ahead with thyroid function. You can't differentiate both of those investigations, right? Both are equally important for you all to go ahead, right? You can't say I don't need thyroid function, I'll go ahead with ultrasound scan. So it should be the next slide. Both are important, so you won't be questioned like that. If it is solitary nodule, you have to assess the structure of the gland and assess the function, right? Then after that you plan for FNA. So you won't be questioned like that, right? Right. That's why they have omitted, they have not given ultrasound scan and TSH as an answers for that, right? Okay. Right. Then if now you do the hemithyroidectomy and sample comes as follicular carcinoma, not the adenoma, then what you will do? Huh? Yes, you do the completion thyroidectomy. That is not the total, it's total thyroidectomy. Yes, but we say it is as completion of thyroidectomy. You remove the rest of the other lobe and the isthmus, right? And again, in the current practice, depending on the nodular size, right, you can decide whether if the follicular is in isthmus, then also do we go for hemithyroidectomy? Follicular neoplasia in isthmus. Yes, you can't. You can't only resect isthmus. Isthmus, you have to sacrifice other lobe, right? And if it is, if this histology comes as malignancy, follicular carcinoma, then definitely you should go for a rest of the completion thyroid, because the more there will be more. How do you describe this lymphatic connections higher in the thyroid? So if the lesion is more towards midline, so there's a high chance of disseminating the neoplasm to other lobe, right? So risk of other lobe involvement is high. Still, yes, management is hemithyroidectomy. And with regard to current practice, now they depending on the size of the nodule, sometimes they, even for malignancies, they satisfy with this lobectomy and address the rest of the remnant micrometastatic tissues by radioiodine. Right? At your level, you don't have to worry much, but world is moving towards, you don't just remove everything. Because in thyroid, you know, there's a term called thyroid paradox, right? That means in benign these thyroid illnesses, you do the total thyroidectomy. In malignancy, you try to preserve as much as possible. World is moving towards that, because they have done several studies, and these thyroid malignancies, when it comes to thyroid malignancies, differentiated thyroid malignancies, papillary carcinoma and follicular carcinoma, those are having excellent prognosis. So they do like that, right? Even with regard to lymph node dissection also, they go on more means they try to preserve as much as possible lymph nodes. Just don't take every lymph nodes out. They assess and do the resection. Minimal resection as much as possible. Right? But at your level, yes, if it is a follicular carcinoma, there's a place for completion of thyroidectomy. You see, in the multidisciplinary team meeting, we'll discuss and decide whether we can just preserve the other lobe or whether we should go ahead with follicular lobectomy. That should be the correct answer. If this said papillary carcinoma, the answer is D. Papillary carcinoma thing is you can diagnose by FNAC, you know. Papillary carcinoma won't there won't be dilemma in papillary carcinoma. Here problem is adenoma and follicular adenoma, that is benign condition, hyperactive nodule is and the follicular carcinoma both will be appeared as same as in the same manner in FNAC. So you can't differentiate whether it is a follicular adenoma, follicular carcinoma. So you go for the histology. Only way of taking histological sample is lobectomy, right? Lobectomy, hemithyroidectomy. In papillary carcinoma, you don't have that line. You diagnose, and depending on the size of the nodule, you plan for the management. In papillary carcinoma also now, depending on size of the nodule and the local invasion, they do this hemithyroidectomies, right? because papillary carcinoma also is having excellent prognosis. You don't have to do total thyroidectomy always, right? But at your level, you can think in malignancies, you do go for total thyroidectomy. But it's not simple as that, right? Even malignancy you can preserve. If it is a nodule less than 4 centimeter, there is always place for do a lobectomy, provided that rest of the gland is not in, all right? Okay, are you clear with that? Right. That's it. Raji race. Then we did 6 linear percent diffuse enlarged thyroid gland for 6 months. Best initial investigation is TSA. Right? We'll go and finish these nodular things, no? Right. Question number 11. 35-year-old male presents with solitary nodule in right lobe of the thyroid gland for 4 weeks duration. Which of the following suggests malignant tumor? Can I quickly answer? Quickly answer. Anybody? Hello? Can you hear me? True, true, false, true, true. Why C false? All true. True, true, false. True, 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 true. Right, right. Yes. What does this recent change of voice implies? What does that mean? What do you suspect? Recurrent laryngeal, yes, local injury, right. Rapid enlargement of the gland, yes, again, it's a sign of neoplasia, more towards malignancy, right? So even if a long-standing goiter is rapid enlargement, you have to think about neoplasia. Past history of thyroiditis. Is this true or false? See, past history of thyroid, how it is, yes, lymphoma is possible. Why? In which condition? Hashimoto's thyroiditis, yes. Right, that's true. Family history of thyroid carcinoma, right? Yes. Again, this genetic component, and when 2A and 2B for this medullary carcinoma, this is genetic component when it comes to the malignant thyroid malignancy. And with regard to that, this solitary nodule, when we were talking about why can't you do a core biopsy or this frozen section without removing the lobe at one go? And there's a genetic assessment as well to replace this thyroid hemithyroidectomy, right? They are trying to do the genetic assessment and diagnose whether it is more benign condition or if the genetic patterns are not there, so it should be a benign condition, so you don't have to do a lobectomy. There's something studies going on in that way as well, by doing genetic studies to omit that thyroid lobectomy step, right? They are trying to prevent unnecessary lobectomy, but for time being, it's the only option, right? For you all to for your interest, right? Just know these facts without confusion, because then only you can have the correct idea, right? It's your career won't be, your exams won't be end by this final MBBS, no? You will go and do PGs, several exams. So this knowledge is important, right? Always right. And this family of thyroid, yes, so this malignant reduce weight, again dissemination, right? All right. 40-year-old female was detected a solitary nodule in right lobe of thyroid gland, which appeared to be hyperactive. It's hyperactive solitary nodule. She was treated with carbimazole and propanol for 4 months. Now she is euthyroid. What is the next best step of management? Before answering this, what is your differential diagnosis on this clinical scenario? Before you go through the answers, you should have a clear idea about this clinical picture. What is the best lead you will have after it's toxic adenoma? Yes, patient is hypothyroid. Yes. To be toxic adenoma. Yes. Then they are treated, and they have treated this hypothyroidism and get the patient in the euthyroid state. Now, what is your plan? How do you address this adenoma? What are the two options to treat this condition? Total thyroidectomy, it's a benign condition, right? Total thyroidectomy is out. And we don't treat medically for 2 years in this toxic adenomas, right? So we do it for Graves, not for this. There are two options, only two options. After patient, you get the patient in euthyroid state, and then you can do the lobectomy, hemithyroidectomy, or you can do the you can try radio ablation, right? Radio ablation, but surgery is superior, right? So answer should be right hemithyroidectomy. That is C. What happens if you do a thyroid surgery in a toxic patient, hypothyroid patient? What is the risk? Anyone? Yes, thyroid storm. It's all the thyroid thyroxine will be released into circulation. The rapid rise of thyroxine, right? Sympathetic overactivity, it's a life-threatening condition. So you have to always get the patient to euthyroid state before doing a surgery, thyroidectomy. Other thing is, what are the indications for thyroidectomy? Surgical intervention in thyroid disease. What are the indications? Anyone? Carcinoma, yes. Benign conditions. Lesion is benign. Still, you go for thyroidectomy. What are the reasons for that? Yes, cosmesis is one. Compression, tracheal and esophageal compression. Yes. Other one is toxic, right? What else? Retrosternal extension, again, is an indication if it is benign, because you can't assess, and if retrosternal extension progressed, surgery will be difficult, patient will get more complications, so it's an indication. And someone has asked very good question. Good question. Is is this radio ablation same as radioiodine therapy? What do you mean by this radioiodine ablation? What do you mean by radioisotope scan and radio ablation? What happens there? How do you assume that there's a papillary carcinoma? You do a total thyroidectomy, and you give a post-thyroidectomy radio ablation, radioiodine treatment. What do you expect from that? What do you expect by giving radioiodine? What is the mechanism? Radio ablation destroy micrometes. Yes, there will be micrometastasis. So there will be very minute amount of thyroid tissue remain in this thyroid bed. So you have to destroy those. And you give TC99 or iodine 123. You calculate the dose according to this. Oncologist will decide the dose according to the grade, severity of the malignancy and type of the histology, and you give, and this this iodine will be uptake by thyroid tissues, right? And this radioactive iodine will damage the DNAs of the thyroid cells, follicles, the micrometes or remaining thyroid cells, and by damaging this DNAs, cells will go into cell death, right? They can't proliferate. So from 8 weeks to 18 weeks, they will regress, right? That is the mechanism. So for you to achieve a good radio ablation effect, you have to maintain. After surgery, you assume you do a thyroidectomy for a malignancy, and you post-operative period, you give high doses of thyroxine most of the time to suppress the gland, the thyroid tissue. Because if TSH immune stimulation also again a proliferative stimuli, so you have to regress. You want to regress the rest of the remaining thyroid follicular cells. You keep the patient in supraphysiological state where TSH will be very minimal. Stimulation will be very minimal. But before doing a radio ablation, you have to omit thyroxines, bring up TSH up to 30, right? Omit diets, advise patient take less diet with less iodine. Omit all the drugs containing iodine. So you have to keep the patient in iodine deprived state. Then once you give the radioiodine, this remaining malignant cells will pick up iodine quickly and they will go into cell damage, right? That is why you keep in this iodine deprived state before radio ablation, right? And after doing radio ablation, there are several. We omit for 2 weeks. What Anjali meant is drugs. Actually, yes, we omit and we bring the TSH up to 30 if possible. Sometimes patients are getting the symptoms, and they have this recombinant TSH, no? Recombinant TSH. Right. That's it. Disregard radio ablation. You kill the remaining follicle tissues, and radioisotope scan. What is the difference between hemithyroidectomy and subtotal thyroid? Subtotal thyroidectomy, you take both the lobes and isthmus, but it's like a difficult surgery, a lot of additions, right? Or if it is benign, now in even multinodular goiter, we don't do subtotal thyroidectomy, but in a difficult surgery, yes, there's a place for doing subtotal thyroidectomy. Means you keep a 1 cc volume margin in regions where this recurrent laryngeal nerve is involved, difficult anatomy. Where there's difficult anatomy, you can't completely take out, but you take almost everything, remaining small amount of thyroid tissue. That is what called subtotal thyroidectomy, either difficult surgery or previously practiced that in multinodular, but no more longer it's not practiced. In multinodular, you should do total thyroidectomy. Otherwise, patient comes with recurrences, right? And repeat surgery will be very difficult. Different between radioisotope and so both are same, right? You do the scan to assess the function, radioisotope, and you give high doses to kill the remaining follicular tissues, right? Same mechanism. How many weeks we start radioiodine therapy following surgery? That's mainly a oncologist's decision, right? Usually in 2 to 3 months, they do the radioiodine therapy, right? All right. Any questions? Thyroidectomy. Hemithyroidectomy, you remove only the lobe, thyroid lobe, and the isthmus, right? Radio ablation therapy is always followed by isotope scan. You do the isotope scan to check whether what are the regions where this radio ablation, radioactive iodine uptake. You check what are the regions where this radioactive iodine has been taken off. So you can have an idea. These are the areas where you have micromets or remaining thyroid tissues or ectopic thyroid tissues are there, right? You can have an idea about the these micromets, remaining thyroid tissues after doing a isotope scan. You do isotope scan after radioablation therapy, detect the you can detect the remaining thyroid follicular tissues after adequate time period, 9 months, 12 months. Again, if you repeat, they don't do frequent isotope scans. It's unnecessary radiation exposure. You can say after 2 years, like you do isotope scan. If it is not visible, there are no more iodine uptakes or no more active thyroid tissue. That means all the previously visible micromets and follicular tissues are disrupted. That's the idea of doing isotope scan after radioablation to detect the points where these micromets are located. Prior to radioiodine, have to stop thyroxine 4 weeks prior to surgery. Four weeks prior to surgery, no. You don't stop thyroxine prior to surgery. You give thyroxine and get the patient into euthyroid state, right? Idea is to bring the patient into euthyroid state when you do the surgery. If the patient is hypothyroid, you treat that. If the patient is hypothyroid, you give thyroxine and bring the patient to euthyroid state, then do the surgery. In this radioiodine ablation, you should keep the patient in iodine deprived state because this remaining thyroid follicular tissues should be in active state, hungry state to take iodine. Otherwise, they won't take. No. So for them, for these remaining tissues to take iodine avidly, you keep the body in an iodine deprived state. Right? That is the idea. Since this question is asking for next best step in FNAC, what I achieved by doing FNAC? hyperactive solitary nodule, you don't do FNAC most of the time, because most of the time those are how this block replacement, that is all out. No, you don't practice block and replacement. You give thyroxine, at the same time you give anti-thyroid drugs. Those are previous treatments of previous era. Even we don't practice now. Do we stop propanol before surgery? No. Propanolol before surgery, if the patient is euthyroid, you don't need, you give propanolol to relieve the sympathetic overact, this tremors and all. You give beta blockers. Once you achieve this euthyroid state, you can stop. Otherwise, in thyrotoxic patient, you won't do the surgery. So you can stop propanol when you achieve the euthyroid state, right? And nothing to do with propanol and surgery. That's a misleading thing, right? Someone has asked, do we have to stop propanol before surgery? That depends on if the patient is asthmatic. Yes, again, it will aggravate. Apart from that, it is not related to surgery. It's related to patient's thyroid status. Patient is thyrotoxic with sympathetic overactive, you give propanol, and before the surgery, anyway, patient should be euthyroid. That means before the surgery, propanol anyway you will stop because you have achieved the euthyroid state. No. Are you clear with that? Are you clear with that? Right. Okay. Then answer for this 12, question number 12, that is thyroid adenoma, right? You get the control and you can do the either hemothyroidectomy or radioablation, right? Okay. As use of carbamazole for 2 years, can you please explain about that? Is in the Graves field. When we do a Graves disease question on Graves disease, we'll explain, right? Question number 13. Euthyroid patient with multinodular goiter started on carbamazole 3 months back. That time she had normal T3 and T4. She was on aspirin and clopidogrel for 1 month for ischemic heart disease. Suddenly she has developed neck swelling and discomfort for 48 hours, which was following are true. Okay. Tell me the answers quickly. What is this clinical condition? What is suspect? What is suspect? Yes, bleeding into cyst. Slip ligate. Yeah, anything. We haven't done a thyroidectomy. Someone has anti-thyroid drugs, carbs, there's nothing like that. You continue drugs, right? Anti-thyroid drugs, everything. You don't have to stop. Why do you stop anti-thyroid drugs prior to surgery? It's not needed, no? Thyroxine and anti-thyroid drugs, you don't stop. Anti-thyroid drugs, you get the control. The thyroxine level, euthyroids get the toxic state control, then do the surgery, right? You don't stop anti-thyroid drugs if the patient is thyrotoxic patient. In Kumar and Clark's, they say you have to stop. Reason? Why? Kumar and Clark is not a surgical book anyway. I will get into that. I don't think you have to get what they say. You have to get the Uttar state, right? Like Samar Prashna pain. Right. Slip ligature, yes. If you have done a thyroidectomy, yes. Here you don't have any slip ligature, no? You haven't ligate anything. It's a goiter with a recent swelling and discomfort for 48 hours. Most possible diagnosis linked to cyst. Right. What are your answers? Stop Carmazole. Is there an indication to start Carmazole in this patient? Best, if it's a best answer, yes, answer should be B. And co-biopsy, if it is a true and false, you don't achieve anything by doing co-biopsy or tracheostomy. If it is a severe, very rare occasions, you get one or two case presentation are there, you get a upper obstruction by bleeding into large cyst. In that stage, you will do a you will secure the upper air by intubating, right? You can't do a tracheostomy in a large goiter, in such a large goiter where you get a upper obstruction by bleeding into cyst. Urgent next CT scan, no, it should stop aspirin. I can't find any indication to start Carmazole, so you can stop here. But if it is best answer the question, single best answer question, answer should be B. Otherwise, if it's true or false, A true, B true, C false, D false, and E also false, right? Right? Okay. Then, question number 14. Hoarseness of voice 4 hours after total thyroid, not a tracheostomy. What are your answers? This is a true false question, right? True, false, true. Yes, hypercalcemia, you won't get hypercalcemia after just 4 hours, right? That is the thing. Otherwise, it can cause hoarseness, laryngostomy, yes, hoarse voice. But 4 hours, no, they won't get hypercalcemia in such immediate period. Hematoma is yes, right? Laryngoedema, they will get hoarseness. Neuropraxia, yes, obvious. Tracheomalacia also will lead to hoarseness. Spethidine, overdose, and hypercalcemia are false, right? What are the complications of thyroidectomy? What are the complications you expect? In tracheomalacia, you can get hoarseness, right? Isn't it immediate? Yes, just after extubation. You are very correct. Just after extubation, you will get tracheomalacia. But 4 hours, in that sense, yeah. I don't know what they will sometimes It will be a bit delayed, and within 4 hours after, no, yeah, this is tracking we can take as false. No, it's just after. So yeah, you are correct. Can hypercalcemia lead to hoarseness? Yes, due to this obstruction, laryngospasm. Yeah, they will get some degree of hoarseness. Means not only due to this vocal cord palsy, due to upper ear obstruction. This is all the phonation. Ethylene, it's false, no? They will get respiratory depression, some degree of this tongue full and black, but they have described it as hoarseness. I couldn't find any complication of jazz. They will get snoring, no? What are the post-operative complications after thyroidectomy? 3 main complications. Three main complications. One is bleeding, and this why they get upper ear obstruction and bleeding. You will get a slip ligate or this inadequate hemolysis achievement. Whatever, they will get a hematoma. They bleed into this hematoma, laryngeal. How they develop laryngeal edema bleeding? Is it direct compression of the hematoma or what? How they get laryngeal edema? Due to this blood accumulation in this muscle compartment, right? Thyroid bed, that will impair this venous congestion, impair the venous drainage. So they will get a edema in larynx. They will develop upper ear obstruction. That's the correct one, not the direct compression, right? And blood is irritative outside the vessels, and there's irritative action, and that will also cause laryngospasm. Laryngoedema, laryngospasm leads to upper ear obstruction. Other one is postoperative complication, hypocalcemia, and third one is recurrent laryngeal nerve palsy. All those three complications lead to upper airway obstruction. Right. That's it. "35-year-old female presented firm nodule in right lobe of thyroid for 3 months. Frequency of situation reported for regular." Yes. Right, Timida. We did this, no? Right. Question number 16. In the management of thyrotoxicosis, incidence of cardiac failure highest in Graves' disease. Is it true or false? What are the answers for this question? What are the answers? Anyway, so true, false, true, false. What are the answers? Cardiac failure highest in Graves, yes, right? They develop cardiac failure due to sympathetic or hyperdynamic circulation. They go into heart failure. In this hyperthyroid, this even this thyroid storm, they develop heart failure, right? Weakness of distal muscle is a prominent feature. What is the answer for that? In hyperthyroidism, they will develop proximal muscle weakness. Yes. Exophthalmos can be unilateral. Thyrotoxicosis, they usually get bilateral exophthalmos. If it is unilateral, always you have to think about local causes, malignancies and what. Okay, antithyroid drugs are used as curative intention in thyrotoxicosis. Yes, in Graves we do. This is part of medical management. sometimes cures, right? And beta blocker should not be stopped before surgery. That's false, right? If you get the control, you can stop. Should not be stopped before. There's nothing like that, right? Idea is to get the euthyroid state before the surgery. Right. Number 17. 6 hours after undergoing thyroidectomy, 36-year-old female patient vomited and having stridor. Cause for this stridor. What is the answer? Answer for 17. This is more common in secondary thyrotoxic cardiac complications. Secondary thyrotoxicosis, what do you mean by secondary thyrotoxicosis? It is due to pituitary thyroid axis problem, pituitary adenomas. Cardiac complications are common in graves. That's right. What was the question? Incidence of cardiac failure highest in Graves' disease. For my knowledge, it's, I think that is true, right? That is the most commonest thyrotoxic state. No? The other things are very rare. Plumbers also incidents, so they are talking incidents of cardiac failure. These are rare conditions. Yeah, I'll check with that, right? 16. 16. Yeah. Right. Answer, best answer for this number 70, yes, it's again laryngeal edema, no? Clear, no? It's after 6 hours, you are vomiting. I don't know, there's a triggering effect. They haven't described as such. Most common cause for laryngeal edema. Stridors should be laryngeal edema. That is the best answer here. Laryngeal spasm, recurrent damage, secondary hemorrhage, Ola. Possible, but best answer should be A. Any different answers? Can't we take B? Even hemorrhage, what happens? They develop laryngeal edema, no? Due to this venous impairment of venous drainage. So that is the ultimate point. Thyroid and we did. Right. Number 19. 30-year-old man with pheochromocytoma and hyperparathyroidism is present with anterior neck lump. What is the most likely thyroid carcinoma he can get? Any idea about this? Medullary carcinoma. Yes, they have given the correct answer here, no? Yeah. It's men syndrome. Which men syndrome? Men 2, 1, 3. Yes, medullary carcinoma. Here, this men. Can you all see this slide? Can you see, no? Can you see this slide? This PowerPoint slide, men 1 and 2. Yes. Okay. Right. This is the multiple endocrine neoplasia 1, 2A and 2B. Now they classify as 2 and 3, right? And 1 there will be pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. When 2 and 3, now newest classification when 2 and 3, earlier 2A and 2B, both are involved in medullary thyroid carcinoma. When 2A, there's a parathyroid hyperplasia and pheochromocytoma. When 2B, they have marphonoid body habitus, pheochromocytoma, and mucosal neuromas, right? And got this. Medullary CA, 25% of medullary carcinoma hereditary as part of when 2 and 3 syndromes of familial medullary carcinomas. So 1/4 of medullary carcinomas are genetic origin. Right? Lack of family history doesn't exclude inherited because skip generations, right? It's an index case of the start of new family. All patients with medullary thyroid cancer should be evaluated for features of MEN2, hyperparathyroidism due to parathyroid tumor, pheochromocytoma of adrenal. MEN3 mucosal neuromas, marphonoid habitus, colonic ganglioneuromatosis, relate corneal nerve fibers. Yeah, marphonoid habitus, typical phases, these four features, right? No span. And the gene mutation is RET, right? Okay. RET mutation. That's about your medullary. Right. "30-year-old female has a solitary nodule. FNS shows follicle neoplasm. What is the most appropriate management? We have described why we don't do co-biopsy yet. Thyroglobulin level, no point. The answer is right? To achieve histology. Again, this same questions repeats, no? 16-year-old girl with diffuse physiological COVID. Check the function. This 20-year-old male presents with midline swelling in the neck. The possibilities. What are the possibilities? Answers, please. Answers for this question. 22. Thyroglobulin cyst. True, false, true, right, almost all. How do you clinically differentiate thyroglobulin cyst from thyroid? Patient comes with anterior neck swelling. Anyway, okay, tell me this. Patient comes with anterior neck swelling. Before you take the history, how do you say this could be thyroid? How do you take? It can be anything. No, patient comes and say there's a neck swelling for this one. Yes, moves with liquidation. Ask the patient to swallow and anatomical position and moves with swallowing. So can be right. How do you differentiate from thyroglobulin cyst? You ask the patient to protrude the tongue with stabilized jaw, as you correctly mentioned, right? So if the thyroglobulin cyst is there, it goes with the tongue. Why is that? What is thyroglobulin cyst? What happens there? What is the embryological basis? Huh? What is the embryological basis for thyroglobulin cyst? Anyone to answer that? Remnant of how the thyroid gland is. Yes, remnant of the pathway. And there's a cyst. It is attached to the foramen cecum. Origin related foramen of cecum means base of the tongue. Right. So it moves in the this protruding tongue out, and so it is most of the time located in the thyroglobulin cyst is located in the midline. Sometimes it lies behind the hyoid bones. You have to take the piece of part of the hyoid bone to exercise, right? When you do the excision of thyroglobulin cyst, sometimes you have to take the part of the hyoid bone out to reach the cyst, right? And goiter, yes, again, thyroid. Branchial cyst, what about branchial cyst? Where it is usually located? It is usually located. Huh? Branchial cyst? Lateral. At which point? It's anterior. It relates to anterior border of the sternocleidomastoid mastoid at the level of upper and middle one junction. No? And there is a pouch between which pouches? Pharyngeal pouches. There's a defect. We all know, can remember that embryological basis. Third and fourth pouch or second and third? Not even second and third or third and fourth. You go and check, right? There's a embryological defect created by development neck between third and fourth pharyngeal pouch. Right? Lipoma and Devon sister, again, yes. Can be midline. Swelling. Anything from skin to thyroid, right? This one, right? Again, regarding this radio ablation, lactating mother underwent radio ablation scan 8 weeks after thyroidectomy, follicular carcinoma. Should refrain from this ablation, radio ablation. Should refrain from breastfeeding. True or false? True. Right. Then avoid conceiving for 6 months. True. Should stay as inpatient for 2 weeks to avoid radiation exposure from me. It's no such thing. They don't keep 2 weeks. They keep it as an inpatient till they complete the therapy and they send the patient home. They have to home isolate, right? They have to keep the distance between adult they have to home isolate for 4 days, like, right? If there are children, they have to keep distance for 6 feet, 6 feet for 3 weeks, as far as I remember. I'll check with that. Or keep in hospital for at least week or 2 before sending. No, week or 2. There's no strict guideline for them to keep 2 weeks, right? 3, 4. Okay, we'll check. Radio ablation, contraindication, pregnancy, and moderate recidiv graves. Post-operative. This thing. Again, the advices, no? Yeah. As far as I remember, it was asked to refrain from breastfeeding, avoid conceiving for 6 months. Should stay 6 months, right? Parenting and mothering for 6 months. Should stay as inpatient for 2 weeks. That's wrong. Should undergo radioisotope scan 6 months. That's also false. They give take the scan after within the first week, then follow up, right? It's not 1 year, then they don't keep inpatient for 2 weeks, right? There's no such guidelines as far as I know. And I can't find a document. This disadvantage radio RRA. It's avoid pregnancy for 6 months, fathering child for 4 months, increase of miscarriages. Hospital stay in isolation is required. It's not 2 weeks, right? Hospital stay till they finish the treatment. Need to stay away from others at a safe distance, 6 feet for a short period. Shouldn't be sleep with an adult for 4 days. Adult for 4 days, pregnant woman and child for 3 weeks. That's what they say, right? I'll clear with that. Okay. Avoid consuming one, and normally we don't. Normally, I don't know that they keep for 2 weeks. There's no, if we keep 2 weeks at hospital, the hospital will continue. At this moment, there's a 1 year long waiting list for radio frequency ablation. Right? Still, at this moment, there's a 1 year waiting list. If you keep them isolated in hospital, that will occupy beds, no? Waiting list will be more longer. I'm not sure anyway. For my knowledge, it's not like that. Anyway, I'll check. Right. Okay, 24. In a solitary thyroid nodule, which of the following indicate malignancy? Nodule occurring in a child. Yes. Extreme of age, it's more towards malignancy, right? Child and the adults. Multiple nodules palpated in the back of the gland. That's false, right? Multiple nodule means more towards benign. History of uptake of radioactive iodine. History of uptake means this nodule, if the nodule is taking radioactive iodine, uptake of radioactive iodine is high in the solitary nodule. That means it's a highly active toxic nodule. That means more towards benign, right? Right? History of irradiation of neck, that is a risk factor for malignancy. Patient presenting marfanoid fetus. Yes, this is MEN3. No, MEN3. Patient may having medullary carcinoma. Okay. So do we follow up with TSH? Radio ablation. Yes, TSH. And if it is, depends on the reason, right? If it is Graves' disease, yes, we can follow up with TSH and these TSH antibodies, right? If it is malignancy, we can use tumor markers, right, to check whether the follicular cells are still active. And later, after 2 years, like, we can repeat the isotope scan. That's how we do, right? Right. Then hyperparathyroidism. Before we go into hyperparathyroidism, we'll finish this thyroid questions, no? 50-year-old lady with a WHO grade 2 multinodular goiter. What do you mean by this grade 2 multinodular goiter? That is palpable, no? Palpable. There are 2A and 2B. In 2B, when you extend the neck, you can see the goiter outside, right? It's out, visible to outside. What are the investigation which would support diagnosis? Same thing, no? You do TSH and ultrasound scan of the neck, then your FNAs, right? This thyroid peroxidase antibodies used for this thyroiditis. Yes, there's a place. Thyroglobulin levels we don't use to diagnose. X-ray of the neck, again, we don't use to diagnose. Take the X-ray of the neck to check the position of the trachea and confirm whether the trachea is deviated or not. Right? So A false, E false. Any questions on that? Question number 27. Right? That's that. A woman who had a multinodular goiter for 2 years duration presented with sudden onset acute pain in the neck. What is the most likely diagnosis? These are this year latest final MBBS common MCQ questions on both of this. This again hemorrhage into nodule. Same thing has been repeated, right? So if you do these questions easily. This is a final MBBS question. This is a common MCQ paper question, right? Both of these, 27 and 28. Again, something to parathyroid, right? And anything we have missed on thyroid before we go into parathyroid? We'll quickly go through some theory parts which will help you to work out things in a rational way before we move into parathyroid, right? Oh, this one, we didn't do this thing, no? Question number 9. Of follicular carcinoma? Did you do this question? Question number 10. We didn't do, no? Right. 9, 10. Regarding follicular carcinoma of thyroid, what are the differentiated thyroid carcinomas? You know, differentiated thyroid carcinomas, follicular, papillary, and this Hurtler cell tumors and medullary, right? What is the carcinoma with best prognosis? Best prognosis, papillary, yes. What is the commonest carcinoma? Commonest thyroid carcinoma, more than 80%, it's papillary. Then comes follicular, right? There are follicular variant of papillary and different variants, right? Right. What are the answers for this question number 10? Follicular carcinoma. Results from long-standing multinodular goiter. What do you say? Yes. You want to answer? Yes, it's true. There's a chance, right? Minor chance. And how it spreads? Papillary through? How does this papillary CA spreads and how does follicular carcinoma spreads? Papillary carcinoma spreads through lymphatics, right? Follicular carcinoma, it's hematogenous mainly. And most of the time, this follicular carcinoma can be present as pathological fractures. They get bone mets and they get fracture. And once you analyze the etiology for pathological fracture, you will find out follicular seed. Right? Or sometimes you feel these pulsatile bone lumps, right? Scalp lumps, which is having this intracranial extension. Again, it is due to follicular carcinoma metastasis, right? Those are different. So it's hematogenous. Metastasis is effectively treated with radioactivity, that's true. Can't be differentiated with FNAC, just follicular carcinoma and adenoma. Can't be differentiated by FNAC. We discussed that. As an excellent prognosis. This word is excellent. Anyway, thyroid carcinoma is having generally excellent prognosis. We talk about mortality in 10 years, 20 years, right? Usually they don't kill. And so to the local disease control, you can achieve a good outcome. Are there those terms, papillary excellent prognosis, follicular good prognosis? You can't just go by words. No, I don't. We go with statistics. Generally, follicular carcinomas having good prognosis. That's what we can say. Things that when they collect the MCQs, they have taken only part of the stem. That may be the reason. In the exam, you will get very clear stems. You can mark whether right or wrong without any hesitance, if you know that. Follicular carcinoma, 5 years old, 6 years. No, it's not. No, it's more than that. We talk about thyroid carcinomas already in 10 years, right? Now, at this moment, right? That's that. And again, this 20-year-old woman presented with 3 months history of goiter and hyperthyroidism, right? Toxic goiter. Which of the following features support the diagnosis of Graves? They haven't described the anatomical picture of the goiter, examination findings. They ask, what are the following features which supports the diagnosis of Graves? Simultaneous appearance of hyperthyroidism features with goiter. What do you say? True, yes. B, reduction of the features with enlargement of thyroid. Quickly send the answers to chat box. Yes, when you get the enlargement of thyroid gland, usually thyroid toxicity will be worse, right? Sense of vertigo. That's not there. Clubbing of the fingers. Yes, that's a feature of hypothyroidism, right? And lid lag also comes in hyperthyroidism. What are the clinical signs which are specific to Graves? Clinical signs which are specific to Graves, clubbing and lid lag, you will elicit in any patient with thyrotoxicosis. What are the clinical signs which are specific to Graves? Anyone? You are asking whether it's proptosis. Lid lag and lid retraction you can see in any thyrotoxicosis, right? That is mainly eye signs apart from lid lag and lid retraction. Exophthalmos, proptosis, chemosis, and exophthalmos and proptosis same. Chemosis, yes. Then ocular muscle paralysis. There is a ophthalmoplegia. Then even they can develop visual loss, right? Those are the there are gradings of eye signs also. End stage, highest grade is visual loss due to involvement of optic nerve. In this Graves disease, you will get this due to immune T cell reaction. You will get soft tissue swelling, retroorbital space, that will lead to proptosis and due to this muscular involvement, they will get ophthalmoplegia, double vision. Due to this hyperactivity of molar muscles, they will get lid lag and lid retraction. And due to its severity, they can't close the eyes. So they will develop chemosis, right? Chemosis. And if you get your optic nerve involvement, you will develop visual loss as well. Pre-tibial mixed edema, again, it's a feature of thyrotoxicosis, not a specific sign for these Graves, right? It's not specific to Graves. Right. We did number 8, right? 7, we did. 6, we did. 5, again. Pheochromocytoma, parathyroidoma, thyroid malignancy, medullary CA, and 2, parathyroid hormone. We did regarding thyroid disease. This one, number 2. Can you answer this? Or do you have any questions on previous question? Hello? Answers for this question number 2. False, 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 true. Only one has answered. You're saying direct muscles. Right? Okay. Antithyroid drugs are superior to surgery in the treatment of multinodular goiter. That's false, right? Multinodular goiter, you can't achieve anything by giving antithyroid, right? Surgery is the best option, right? Radioactive iodine is superior to surgery in the treatment of toxic nodular goiter. No, toxic adenomas, toxic nodular goiter. Surgery is the best. There are pros and cons, right? Surgery, there is a risk of damaging recurrent laryngeal nerve and external laryngeal nerve. Parathyroid, the risk is there. In radioactive iodine, again, there is of this pros and cons, right? Radiation exposure, right? Teratogenicity, right? Miscarriages, all this. So, but best option is surgery. Radioactive iodine is not superior. It's false. Papillary carcinoma is a complication of long-standing multinodular goiter. That's again true. Goiter with grade 2, WHO grade 2 classification, easily visible. That is false. It is palpable. Easily visible now to be visible when you extend the neck, right? We discussed that. Unilateral cervical lymphadenopathy can be a presentation of thyroid carcinoma. Yes, papillary carcinoma usually they comes with lymphadenopathy. And when you do a scan and assess, there will be nodules, solid nodules. And once you do the FNAC, there will be papillary, right? And question number 1. Right. So, see false, right? That's follicular. Papillary CA also there is a possibility, right? You are talking regarding this multinodular goiter. It's not only follicular, it's papillary. Also developing papillary and follicular both. Right? That's it. 50-year-old woman with a benign multinodular goiter for last 8 years. Question number 1 we did, no? All right. Question number 1 we did. Okay. We'll just rush through this thing, right? Goiter we did. Clinical stage we did. Thyrotoxicosis, just clinical features. There are metabolic features related to cardiovascular system, GIT, CNS, skin, GU, right? Metabolic loss of weight despite increased appetite, heat intolerance, excessive sweating, serious palpitation, angina, exertional dyspnea. GIT, increased appetite and defecation. It's not diarrhea, right? Increased defecation. CNS tremors, anxiety, agitation, restlessness, rapid speech with regard to skin, alopecia, vitiligo, graves. GU, loss of libido, erectile dysfunction, oligomenorrhea, anemia in females, nocturia, and frequency of urination. Signs, leg and lid retraction occurs in any thyrotoxicosis, exophthalmos, ophthalmoplegia, corneal involvement, and sight loss only in graves. Right? Is muscle wasting, tremors in tongue, eyesight, scalp, alopecia, face muscle wasting, mouth tremors in tongue, neck goiter, shoulder, there's proximal myopathy and wasting of shoulder girdles. When you examine hands in thyroid examination, small muscle wasting, warm and erythematous skin, moisture, sweating, tremors, thyroid acropathy and pulmonary will be there, right? This is acropathy, soft tissue swelling in the hand with clubbing of the fingers. There is soft tissue swelling and clubbing of the fingers. That is called thyroid acropathy. Plumber nails, separation of nail bed from nail plate from the nail bed, right? That is called plumber nails. And CVS, you get tachycardia, arrhythmia, systolic hypertension, widened pulse pressure, congestive heart failure. In legs, you get hyperreflexia and pretibial mixity due to this hyaluronic acid deposition. And how do you evaluate thyroid nodule? We discussed this in most of the questions were regarding nodule, thyroid nodule evaluation. You have to decide, you have to check whether this nodule is solitary or nodule, dominant, right? Solitary nodule, dominant nodule, or multinodule. There is solid or cystic, right? You can address these two factors by your examination as well, right? Then whether it is benign or malignant by history, again, history and examination. Benign causes for thyroid nodules can be non-neoplastic or neoplastic. Non-neoplastic causes will be multinodular goiter, thyroiditis, and cyst, simple cyst. Neoplastic is causes for benign nodules, follicular adenoma and earthless cell adenoma. Malignant causes for thyroid nodules, any primary malignancy and metastatic thyroid deposits from breast or renal cell carcinoma, right? Primary carcinomas we discussed papillary, follicular, medullary, and earthless cells, right? And cancer risk in thyroid, we discussed that question. Thyroid nodule in children carries high risk, right? Age more than 60 again carries high risk for cancer. Solitary carries twice the risk than dominant, right? Solid again, risk is twice when you compare cystic. Male gender carries twice the risk than female. Size of the nodule, if it is more than 2 centimeters, it is more risky than less than 2. Past history of irradiation, neck irradiation, bone marrow transplant, whole body series, all carries high radiation risk and risk of thyroid malignancy, papillary. And high TSH, if the patient is hypothyroid, cancer risk is high, right? Other way around, if the patient is hyperthyroid, that means the TSH low, malignancy is less likely, not unlikely, it's less likely. And then a family history. If there's a strong family history, chance of being thyroid nodule, being malignancy is high. Hashimoto's thyroiditis when it comes to lymphoma, and obesity also risk factor. Evaluation again, history and examination, TSH and ultrasound. History. We did recent rapid enlargement, local invasion, obstructive features, and risk factors, malignancy we discussed, and thyroid status we have to check. And apart from that, we are assessed for this fitness for the surgery, right? Examination, goiter. When you examine the thyroid gland and get the idea whether it is nodular enlargement or diffuse. If it is nodular, it is solitary or dominant. There is solid nodular cystic one. It is tender or non-tender, right? Then you examine the cervical lymph nodes. And are there any lymphadenopathy and consistent whether it is hard or not? Then look for this hyper and hypothyroid signs, right? From the eye signs, hands, right? Pulse rate, CVS assessment, legs, reflexes, everything. And you look for distal metastasis, skull lumps, lungs, then the bone pain, fractures, right? All these things should be checked. Then comes the thyroid function, TSH plus or minus T3, T4, and ultrasound scan neck. Ultrasound scan neck, you assess the thyroid gland and the lymph node assessment as well. If there's suspicious nodule, size of the suspicious nodule, features of malignancy, microcalcifications, this irregular margins, irregular surface, vascularity, high vascularity, taller than wide width, right? And they gives a report according to thyroids, right? And they direct you to do FNA, or they will say FNA is not needed, right? That is according to thyroid score system. Regarding FNAC, we do FNAC usually under ultrasound guidance now. We don't practice FNAC without ultrasound guidance, current practice. And 25 gauge needle, we do under local anesthesia. Bethesda classification 1 to 6, 1 incomplete assessment, you need to repeat it. 2 benign, 3 ATP of unknown significance. 4 follicular neoplasm, 5 suspicious malignancy, 6 malignant. FNA features of papillary CA and follicular CA. Do you have any idea? Anyone to tell about features of papillary CA in FNAs? Some of our bodies, yes. Papillary projections, often in nuclear. Follicular CA is follicular cells, right? It resembles follicular cells. And you can't differentiate follicular carcinoma from adenoma, right? Capsular and vascular invasion cannot be assessed by FNAs, right? Then this thyroid scintigraphy, that's with the thyroid radioisotope scan, we use TC99 or iodine-123, determines functional status. If you find a nodule and patient is hyperthyroid, you check whether this nodule is hyperactive, whether this patient is thyrotoxic due to this nodule or not. If the nodule is thyrotoxic, it means more likely it is benign, but rare chance it can become malignant. So you can manage it medical therapy, right? If it's cold nodule, more chance towards to malignancy, so you should do FNAC, right? And this tumor markers calcitonin for medullary carcinoma, thyroid autoantibodies to this check thyroiditis, serum antithyroid peroxide antibodies to diagnose Hashimoto's, antibodies against these receptors to diagnose this supposed diagnosis of Graves. Indication of surgery, thyroidectomy, cancer, compression, thyrotoxicosis, retrosternal extension, and cosmetic. Right? Thyroid malignancies, differentiate malignancies, papillary follicular Hurther cells, medullary, then medullary CA, anaplastic, right? Medullary CA arises from parafollicular C cells, so tumor marker is calcitonin, right? Anaplastic carries the worst prognosis, and the rare malignancy worst prognosis, right? And we did this. We have to mention, if the patient is on dysphagia, always you have to think about other causes as well, right? It's rare symptoms due to thyroid. So always you do upper GI and exclude esophageal carcinoma, right? Before you relate it to thyroid goit, right? Prognosis: 10-year survival. Follicular CA 85%, papillary CA 93%, right? Earthly cell cancer 76%, and you can't give radioiodine ablation for earthly cell, so you have to do the radical surgical excision. Right? Only 9% will die from the disease. Okay. Medullary carcinoma, thyroid genetics we discussed. Anaplastic CA, rarest thyroid malignancy, poor prognosis, presentation will be pre-existing goiter in 80% cases with recent rapid enlargement and local invasion. 50% have distant mets on presentation. Examination, you will find hard mass fixed with ischemic metastatic nodules with excessive obstruction and Horner syndrome. All these are due to sympathetic plexus invasion, right? Sympathetic trunk invasion and surrounding structures invasion, right? Circle response. In post-op management after thyroidectomy for malignancies, you should give thyroxine 2 micrograms per kilogram, and you have to keep the patient in suppressive state, TSH in 0.2, right? 0.122 level. But again, when it is the elderly population, you have to balance risk versus benefit. They will develop this cardiac complications. If you give high doses, then you have to think about those factors and titrate thyroxine. Those usually after malignancy, you should keep the patient in the suppressive state, TSA suppressive state. That means supraphysiological thyroxine doses. Right? We talked about radioactive iodine ablation, patient preparation and side effects. And this radioactive iodine collects in this salivary glands and bladder. You have to hydrate the patient well and keep them adequately urinating, and they have to we have to advise patient take limes and these things to increase salivation, right? And they will get this iodinitis, taste sensations, defaulted taste sensations, so on, right? Little bit of Graves' disease. It's an autoimmune thyroid disease caused by the production of autoantibodies, IgG autoantibodies directed against the thyroid receptor. Antibodies bind to and activate the receptor, causing autonomous production of thyroid hormones. These are eye signs. Early stages, they get only retraction and lid lag, then soft tissue involvement, periorbital edema, proptosis, extraocular muscle involvement. It's ophthalmoplegia, corneal involvement, side loss, right? This is the old from no sides to you get side loss. This is your proptosis. The lid lag means when you ask the patient to get move the eyeball from up to down with your finger, it comes with late due to hyperactivity of Muller muscle. Sympathetic coactivity. You can visualize the cornea throughout. That is lid retraction, right? Throughout the eyeball, right? Below and upwards. Right, that's it. We'll move on to this parathyroid thing, right? parathyroid. It's a brownish yellow, right? 4 glands, 2 pair of glands, superior and inferior. Thyroid tissues are deep red. Parathyroid is a brownish yellow. Arteries supply from inferior thyroid. And actions with parathyroid hormone. It converts the 25-hydroxycholecalciferol into 125-hydroxycholecalciferol, dihydroxycholecalciferol by stimulating 1-alpha hydroxylase enzyme, right? And then it increases this calcium and phosphate resorption from the bone by increasing osteoclast activity, right? Then parathyroid hormone directly acts on renal tubules and increases the calcium resorption and increases the phosphate excretion. Right? Vitamin D acts on gut and increases the calcium absorption, calcium and phosphate absorption. Net effect is calcium is restored, phosphate is unchanged. Features of primary hyperparathyroidism, that means due to hypercalcemia due to parathyroid adenoma or parathyroid hyperactivity, parathyroid gland hyperactivity, you get stones, bones, abdominal groans, psychic moans, and other symptoms. Right? Renal stones, nephrocalcinosis, polyuria, polydipsia, uremia. Bones, you get osteoarthritis fibrosa, right? Subperiosteal resorption, osteocalcitomas, and bone cysts. Radiologically, osteoporotic bones, right? And abdominal symptoms, constipation, vomiting, nausea, peptic ulcer, and pancreatitis. Psychic symptoms, depression, memory loss, psychosis, personality changes. And these other symptoms, proximal muscle weakness and keratitis conjunctiva. Right? Okay, shall we move on to the rest of the MCQs then? Parathyroid hormone is a answers for this quickly. Tell me the answers. Glycoprotein, what is the biomechanical basis? Is it a peptide? Secreted under control of anterior pituitary? No, it's regulated by serum calcium level. Direct acts on the intestine to absorb calcium? No, it won't act directly. It converts with vitamin D2 to vitamin D3, right? Vitamin D3 acts on gut to increase the calcium absorption. Increases plasma phosphate concentration in the normal heart? No. Net effect is it won't increase or decrease either, but it increases the phosphate excretion, right? Basically, by its direct effect. By indirect effect through the vitamin D3, it increases the absorption from the gut. So net effect is parathyroid hormone won't change the phosphate levels. Right? Promotes renal hydroxylation of vitamin D. Yes, that's true. Right? Then any questions we missed on this thyroid? No? Primary hyperparathyroidism, hyperphosphatemia. It's false, right? Pancreatic carcinoma. No, they won't get pancreatic carcinoma. They will get pancreatitis. Peptic ulcer is just urinary calculus, just acute pancreatitis, true, right? True or false regarding features of hyperparathyroidism. Vomiting true, polyuria true, diarrhea false. They will get constipation. Pathological factors yes, osteopenia, high osteoclastic activity. Sclerotic lesion seen on X-ray false. It's osteopenic, osteolytic lesions, right? Are you following me up? Or go on. '29. Question number 29. Following. Okay. Question number 29. Give me the answer. 60-year-old woman present with recent onset backache. X-ray spine shows fracture including first and second lumbar vertebra. The serum investigation as follows. Calcium 2.2 low. Phosphate 1.03 low. Creatinine 1.1. Which is the most probable reason for the above presentation? Give me the answer. Anyone to ask that question? Anyone? What happens in this primary hyperparathyroidism? It's this parathyroid gland produces more parathyroid hormone. Calcium is high, right? Yes. What happens in secondary hyperparathyroidism? It happens when there is a vitamin deficiency, CKD, right? Normal low calcium, yes. Renal failure. We try to compensate, right? So here creatinine is 1.1, 1.1. So what does that mean, indicate? Not secondary, yes. Then what is the answer? All will be high in tertiary means due to this compensate mechanism, as it go on, there will be autonomous activity, parathyroid gland overcompensation, right? That is what happened in tertiary hyperparathyroidism. It tries to compensate. It compensate. Parathyroid gland tries to compensate, and it becomes autonomous. And due to increased parathyroid hormone secretion, patient will be hypercalcemic. So in metastatic cancer, what happens? Again, osteolytic. Patient will be hypercalcemic, right? Not hypo. So answer is, now you can work out, no? What is the answer now? V. Yes, this is a question from final MBBS, right? Final MBBS paper. Last April, no? 65-year-old smoker presented with hard, non-tender lump in the carotid triangle of the neck. Chest X-ray was normal. Ultrasound scan, neck revealed a lymph node, and FNAC revealed squamous cell carcinoma. What is the most appropriate next investigation to diagnose? What is this condition? So osteoporosis all or no? Not really, no? Osteoporosis, you get hypercalcemia as well. Who says it's serum calcium normal? Osteoporosis, I don't. It's not phosphate. What is this? You have a metastasis without unknown primary. This is called carcinoma of unknown primary. So you have to look for the primary lesion. So what are the regions which drains which are drained to cervical lymph nodes? So you have to check the larynx, upper airway and GI tract, right? It's where it can be laryngeal carcinoma. Then this is where you'll see it can be either GI or respiratory. So you have to do the endoscopy and assess the aerodigestion tract, GI tract and respiratory, right? This is the case. This clinical scenario is called CUP, carcinoma of unknown primary. And thyroid malignancy also presents like that, lymph node, only the lymph node, right? They comes with the lymphadenopathy. When you investigate, you will find a goiter. Here they have done ultrasound scan, neck, only lymph node, no goiter mentioned, right? So that's it. We have completed almost all the things. Do you have any questions? Someone asked, so isn't it secondary hypopara due to vitamin deficiency? How do you say so? Vitamin D deficiency, how do you say so? What are the evidence to say this is secondary hypoparathyroidism due to question number 29, vitamin D deficiency? In evidence, with the given details and clinical scenario, we have to decide, no? Right? Okay. Then, any questions? Right. Anyway, do you have to know about low risk group, high risk in managing malignancy? Yes. That means high risk means patients with risk factors, right? And at your level, they won't expect more than that. You should know what are the risk factors for thyroid carcinoma. We have discussed, no? Family history. Genetic involvement. Apart from that, this radiation, age, gender, right? This past history of malignancies, those things, right? And occupational hazard is also carries some degree of risk to this papillary disease, right? Orthopedic surgeons are at some sort of risk. Right, then a message to pass you all. What's that? We're going to start our SCQ discussion on this Saturday. If anyone likes, you all can join, right? I'll post the any questions? What is the lymph node dissection level that we go? That nice question, right? That's exactly very good question. So, and in breast CA, we do this level 2 axial clearance, no? In this thyroid, again, if there are involved cervical lymphadenopathy, you do the FNS and confirm, and you with this level 6, that is anterior lymph node compartment, you reset the lateral region, right? Usually now they say if the detected lymph nodes are at level 3, one above and one below resection will be enough. Previously, they said 2 to 2A to 5B resection is needed in lateral dissection with central dissection of level 6, right? That is level, you omit level 1 and level 7 unless you have detected by your CTs. Level 1 usually it is not involved in thyroid. Level 7 rarely you will get involved, right? So level 2 to level 6 is the lymph node dissection, right? In thyroid carcinoma, lymph node metastasis, right? Any questions? Any more questions? So in which carcinoma we definitely go for lymph node dissection? There are no such thing. If you have lymph node involvement, you should do the lymph node dissection, right? In papillary and follicular both, and Hertzler cell, definitely you have to go for adequate surgical excision because you can't address the remaining tissues by this adjuvant iodine ablation, right? Radioiodine ablation, right? All right. Any more questions? Is that all? Is that all? Yes. Okay. Then to place a thyroglobulin follow-up. That's in your follicular C, right? And papillary. Yes, it's a tumor marker, no? If it rises, that means you have a recurrence, right? That is the thing. It is being used as tumor marker, right? We'll start our sequence on Saturday, right? I'm sorry I couldn't do that on last Monday. We'll start on Saturday, right? Okay, then. Thank you very much. Any questions? Any more? – 20 minutes more if you want, you can ask English. And give me the feedbacks, right? How I'm also new to this thing. So give me your feedbacks. If you have any questions, you can talk to me, drop me a message, and I'll find out. I try my best to answer those, right? And that's it.